Good evening, respected teachers and panelists and everyone present today. Today, I'm going to present a journal club on the rituximab trial. As we know, the GP and MP are the major subgroups of ANCA-associated vasculitis. Untreated ANCA-associated vasculitis has a mortality of around 90% within the first 2 years. Glucocorticoids and cyclophosphamide induces remission in about 80% of patients at 1 year. And B lymphocytes contribute to the pathogenesis of ANCA-associated vasculitis. Rituximab is an effective therapy for induction of remission and is superior to cyclophosphamide for treatment of relapsing disease. However, over 50% of patients do relapse within the first years of diagnosis. So the risk factors for relapse are the diagnosis of GPA, PR3 positivity, low serum creatinine at presentation, extensive disease, ENT involvement, a history of relapse predicts future relapses, ANCA positivity at the end of induction, and a rise of ANCA titer. Low cyclophosphamide dose, immunosuppressive withdrawal, and glucocorticoid withdrawal are also associated with higher risks of relapses. So there have been multiple landmark trials of multiple drugs for ANCA-associated vasculitis. There have been mainly 4 landmark trials of rituximab in ANCA vasculitis. The first being the first two being for induction, that is the RAVE and rituximab, and the other two, the MENRITSUN and the rituximab trial. So in the RAVE trial, which was mainly done for the induction, it was found that rituximab therapy was non-inferior to cyclophosphamide for the treatment of induction of remission of severe ANCA-associated vasculitis, and was found to be superior in cases of relapsing disease. In the rituximab trial, in which rituximab was used in combination with cyclophosphamide and was compared with cyclophosphamide alone, it was found that the combination use of rituximab and cyclophosphamide was not superior to standard intravenous cyclophosphamide therapy. In the MENRITSUN 1 trial, rituximab was found to be superior to azathioprine as a maintenance strategy in a largely new cases of ANCA-associated vasculitis, where the induction was done with cyclophosphamide and glucocorticoids. Rituximab in ANCA-associated vasculitis have been associated with increased risk of infection and development of hypogammaglobulinemia. So the research gap is that we don't know the optimal strategy to maintain remission following induction with rituximab in patients with relapsing disease, because the MENRITSUN trial was mainly done in new patients, and those patients were induced with cyclophosphamide. So the rituximab trial, the objective was to assess whether fixed interval rituximab was superior to azathioprine for the maintenance of remission following induction with rituximab and glucocorticoids in patients with relapsing ANCA vasculitis. It was an international multi-center open-label randomized controlled trial. The study design, it had 3 phases. The induction phase for the first 2 months, where the patients with relapsing disease were induced with rituximab, 4 doses at 375 milligram per meter square per week with oral prednisolone, and patients who achieved remission were randomized to either rituximab or azathioprine, and induction maintenance therapy was given for 4 to 24 months. And there was a follow-up phase up to 36 to 48 months, where the patients were off therapy and they were follow-up for relapses. The inclusion criteria were the age more than 15 years, diagnosis of GPA or MPA, current of prior positive test for PR3 ANCA or MPO ANCA, and disease relapse defined by 1 major or 3 minor relapses according to the VIVAS score. The exclusion criteria was recipient of any biological B-cell depleting agents within the previous 6 months, use of IVIG or plasma exchange or anti-TNF therapy within the previous 3 months, and use of alemtuzumab or ATG within the previous 12 months. And also patients with other multi-system autoimmune diseases were excluded, like EGPA, renal limited vasculitis, SLE, triloglomerular vasculitis were all excluded. The study area, excuse me, the study area, 29 centers participated in the trial from countries like the US, Canada, Europe, Japan, Australia, and New Zealand. The study period was from 2013 to 16. Regarding the randomization, patients who achieved disease remission at 4 months were randomized into the maintenance phase using a web-based system in a 1:1 ratio to receive either rituximab or azathioprine. They were stratified and randomization with respect to ANCA type, PR3 or MPO, relapse type, severe or non-severe, and the oral glucocorticoid induction regime, the high dose and low dose. High dose was defined as 1 milligram per kg per day, and low dose as 0.5 milligram per kg per day. During the maintenance phase, patients who were randomized to rituximab received 5 doses of rituximab, 1 gram every 4 months at 4, 8, 12, 16, and 20th month, and or azathioprine given at 2 milligram per kg per day till 24 months, and after which it was reduced to 50% and stopped at 24 months. Glucocorticoids, only patients who could achieve a dose of 10 milligram prednisolone or less at 4 months were randomized, after which it was reduced to 5 milligram at 6 months and 2.5 at 16 and stopped at 20 months. They were followed up, and clinical laboratory and patient-reported outcomes were performed at 4-monthly interval. Excuse me. This is the consort diagram, which showed a total of 188 patients were enrolled in the trial, and 187 patients received induction therapy. At month 4, 179 patients completed the induction phase, and out of which 170 patients who achieved remission were randomized, 85 in the azathioprine group and 85 in the rituximab group. They were put in to maintenance phase, and they were followed up. And 78 patients completed the maintenance phase in both the arms, and 70 and 71 patients in the azathioprine and rituximab group completed the follow-up phase. The outcomes, the primary outcome was done from randomization to disease relapse. The secondary outcome included the proportion of patients who maintained remission at the end of the maintenance phase, and time to major relapse, cumulative accrual of damage measurement, cumulative glucocorticoid exposure, health-related quality of life, serious adverse effects, hypogammaglobulinemia, and infections. Regarding the statistical analysis, the sample size was calculated to be around 160, with the goal of achieving 90% power with the alternative hypothesis of hazard ratio of 0.4 at the 5% significance level. The assumptions was that there will be around 5% dropout rate, and the relapse-free rate of 75% for rituximab and 50% for azathioprine at 48 months. The analysis, it was intention to treat analysis based on Cox proportional hazard model, and Kaplan-Meier curve for estimation of relapse-free survival, and adjusted for the stratification factors with multivariate analysis for risks of hypoglycemia was done. Regarding the results, 180 patients were enrolled, out of which 170 were randomized to receive rituximab for azathioprine. Out of these, 72% were PR3 ANCA positive, most of the majority of them. 62% had major disease activity, and 28% only 28% received the high-dose glucocorticoid regime. Regarding the baseline characteristics, it was similar in both the rituximab and the azathioprine group. The patient population mainly consisted of the white population, around 90% in each arm, and the Asians constituted only 6%. Regarding the efficacy, it was found that rituximab was superior in preventing of major as well as minor relapses, with hazard ratio of 0.4, 0.35, and 0.45 during the whole study, the maintenance phase and the follow-up phase respectively. And the relapse-free survival rate at 24 months was 0.85 for rituximab group and 0.65 for azathioprine group. And at the end of the trial, that is 48 months, it was 0.5 and 0.22 for the rituximab and azathioprine group respectively. This shows the Kaplan-Meier curve for the relapse-free survival probability. The upper curve shows the in blue shows the rituximab curve, and the lower one, the red one, shows the azathioprine curve. So during the whole trial, it was found that about 45% of patients in the rituximab group experienced relapses, compared with 71% of patients in the azathioprine group. And during the maintenance phase only, that is up till 24 months, 15% in the rituximab group experienced relapses, compared to 38% in the azathioprine group. Relapse-free survival rate was 0.85% for the rituximab group and 0.6 for the azathioprine group. During the follow-up phase, there were 33 relapses in the rituximab group, compared with 49 relapses in the azathioprine group. 5 patients in the rituximab group experienced major relapses, compared to 11 patients in the azathioprine group. And the rate of continued remission was 0.5% for the rituximab and 0.22 for the azathioprine group. Regarding glucocorticoid use, neither a glucocorticoid induction regime, whether high dose or low dose, nor the ANCA subtype, whether the PR3 or MPO ANCA, influenced the risk of relapses. Individuals who entered the trial with a major VVAS item at relapse were less likely to experience a relapse during the trial. This shows that only the use of rituximab compared to azathioprine was associated with a lower risk of relapse. However, the induction regime, whether high dose or low dose glucocorticoid or the ANCA subtype, did not have a significant correlation with the risk of relapse. However, the type of relapse, that is the severe relapse, were associated with lower risks of future relapses. The compliance with the treatment was good in both the arms, 95% and 92% in the rituximab and azathioprine group respectively. The cumulative glucocorticoid exposure was same in both the arms, that is 2,100 milligrams median in both the rituximab and the azathioprine group. And at the end of the maintenance phase, that is 24 months, 29% in the rituximab group and 46% in the azathioprine group were still receiving glucocorticoids. There was no difference in the accrual damage between the two groups. Quality of life measure, there was no difference in the observed in the quality of life measure using the short form 36 score. Regarding the CD19 positivity, During the induction phase, the median CD19 count was 0 in both the rituximab and the azathioprine group. However, during the maintenance phase, whereas the CD19 count was 0 in the rituximab group, it had increased to 0.9, 0.1 and 0.3 at 12 and 24 months in the azathioprine group. However, during the follow-up phase, the median CD19 counts were lower in the azathioprine group because these patients had a higher risk of relapse, and rituximab was again used for induction, induction in these patients, and hence CD19 counts were lower in these patients. This graph shows the CD19 count between the azathioprine and the rituximab group. Regarding the serious adverse effects, it was found to be 44% in the rituximab group and 56% in the azathioprine group, which was not statistically significant. There was no difference in the time to first serious adverse effect between the groups. This Kaplan-Meier curve shows the, the serious adverse effects pre-survival probability between the rituximab and the azathioprine group. Severe infections occurred in 18% in the rituximab group compared to 22% in the azathioprine group, which was similar, and 42% in the rituximab group compared to 31% of patients in the azathioprine group had a plasma IgG level less than 5 grams per liter, which was numerically higher in rituximab group, but not statistically significant. And around 5% in the rituximab group and 6% in the azathioprine group developed new malignancies. The various serious infections that occurred in the during the trial included patients with appendicitis, bronchitis, cellulitis, pneumonia, urinary tract infections, sepsis, sinusitis. So in discussion, rituximab was found to be superior to azathioprine for the prevention of recurrent disease in patients with ANCA-associated vasculitis with a prior history of relapse following a reinduction of remission with rituximab and glucocorticoids. The lower average glucocorticoid exposure was found in the rituximab group over the total trial duration. In the MAINRICH-SUN trial, which was mainly done in patients with new onset ANCA vasculitis after induction with cyclophosphamide, there also they had found that the superiority of rituximab over azathioprine for the prevention of relapse following induction of remission with cyclophosphamide. The patients were mainly newly diagnosed patients in that trial. And the higher relapse rate was found in this trial compared with MAINRICH-SUN, probably because in the present trial, the rituximab trial, patients of the relapsing disease were included, and they were at a higher risk of relapse anyway. And both the major and minor relapses were reported in the rituximab trial, whereas in the MAINRICH-SUN trial, only the major relapses were included. And the follow-up period was also longer, 48 months, whereas in MAINRICH-SUN trial, it was only 28 months. The cumulative rituximab dose was around 5 grams, 5 grams in the present trial, which was double that used in the MAINRICH-SUN trial. Yet the relapse rate was quite significant at 15% in the rituximab group. There was also a lower risk of relapse in those with major VVAS item at enrollment. And after discontinuation of therapy, relapses were frequent in both groups, indicating that the benefit of rituximab was not sustained beyond the treatment period. Side effects and infections were common in both the arms, and the median plasma IgG level was remained stable in both the rituximab and the azathioprine group. Then the higher glucocorticoid exposure and lower baseline plasma IgG level was associated with the development of hypogammaglobulinemia. The strengths of the trial included that this was the largest cohort of patients with relapsing ANCA vasculitis. There was a centralized randomization and recruitment from 29 centers across four continents and 7 countries. There was a low rate of treatment crossover, and there was a long period of follow-up compared to other trials for 48 months. The limitations of the study included that it was an open label trial, and the extended use of glucocorticoid was employed in this trial. So in conclusion, rituximab is more effective than azathioprine for prevention of relapse for patients with ANCA vasculitis with relapsing disease who were induced with rituximab and glucocorticoids. This confirms the efficacy of rituximab for induction of remission for relapsing disease and a standard of care for maintenance therapy. And despite the high dose of rituximab used in this regime, relapses still occurred, especially after stopping of rituximab. Thank you.
Thank you, Dr. Sudipta, for the nice presentation. Before we move on to the questions, I invite Dr. Pragya Kumar from AIIMS Patna to present on the statistical part with importance on the hazard ratios, which we had seen in this study. And simultaneously, I request all the attendees to post their queries in the chat box, and we'll be taking them up and discuss the journal shortly. Dr. Pragya Kumar?
Yes, I'm doing it. Actually, there is some problem with my camera, so I'm just sharing my screen. Before I move to, am I audible to everyone?
Yes, ma'am, you're audible. And
Okay.
Dr. Sudipta, you can stop sharing so that ma'am can share. Yeah.
So is my screen visible to all of you?
Yeah, it is visible.
Okay, so before I move to the this hazard ratio and the Kaplan-Meier analysis, I would like to show the sample size calculation in this article, because I think the major of my task is to show about the sample size calculation. So if you can see it, I'll just show. There's some problem with my video, that's why I'm not. Yes, so here you can see whenever we calculate our sample size, basically we take two outcomes. That is, it can be in the form of mean or it can be in the form of proportion. So if you see this article, basically this article is saying that the relapse is 50% in case of the azathioprine and 25% in the case of rituximab. So the author is saying that he has done the superiority trial, but if you see the write-up, there they have written that superiority margin they have not mentioned. So basically they have taken 164 patients, and if you can see it, this is the Statulator, one of the software to calculate the basically sample size. So here you can see there are three options. There is a non-inferiority trial, there is a superiority trial, and there is an equivalence trial. So if we focus on this, basically how we should have done it, like the expected outcome proportion in the reference group, that was 50% of relapse was there in the azathioprine. So I will make it to 50% and 25% relapse. So in the reference group was the rituximab, sorry, it was 25%. And if you see the in the test group, it was 50%. So if you make it to 50 and 25%, But you can see that in the article, they have not mentioned the superiority margin. So how they have done it, basically they have taken this formula of equality trial. So in equality trial, what happens that you only mention the difference in proportion, and that's what they have done it. So in the reference group, the relapse rate was 50%, so they have make it to 50. And in the test group, they have made it to 25%. So if you, and power, they have kept it at 90%. So if I press calculate, you can see the total sample size should have been 126, assuming an equal group size, 80% of power, and 95% of the confidence interval or alpha error of 0.05. Since if I make it to 90%, so I'll increase this desired pi to 90% because they have taken it at 90%. Then if you calculate again, I did not update it. Let me do it. 90. And I'll update it. So you can see it is 82. So 82 means a total of 164. And you can see this article. Is this article is visible at my screen or only the statulator is there? Because new share. So let me show you the article. So you can see here that the sample size part. So the enrollment continued until at least 160 patients were randomized. This sample size was calculated based on a goal of achieving 90% power. So they have kept this power as a 90%. Under the alternative hypothesis, they have written that the hazard ratio they have taken as 0.42. But I have tried calculating this hazard ratio, but it was not coming. When I used this formula, like 75% of the relapse-free rate. So what do I mean by this relapse-free rate? That means 25% was the relapse in this case, in the rituximab arm, and in azathioprine arm, it was 50%. That means 50% was relapse. So that's why I took that. And you can see I have used this 25% and this. So this 25% and 50% keeping a power of 82, it is coming to 164. This was regarding the sample size calculation. Now coming to the hazard ratio and the Kaplan-Meier survival analysis. So I have just created this data set in Jamovi. So you can see that the author has used our software for analysis. And if I share this, yes. So this is the Jamovi interface, and you can see this is the data. So I will first explain the variables. We have just created a dummy data for this demonstration purpose. And you can see all the variables which I have taken: the age of the individual, gender as male and female, duration of that pre-existing disease. And these are the two groups, rituximab group, and the next group is the azathioprine. This is the azathioprine, and I have given this as a 1A and 1B. And this is depending on the ANCA type, depending on anti-myeloperoxidase or anti-proteinase 3. And the disease severity also I have kept as like non-severe, severe, and then event occurred and not occurred. And this is the time to event data. This is the most important data in survival analysis, because I need the time for that event to occur. And then the second, when the event has not occurred, we call it as a censoring. So there is an option in Jamovi, and as I said that this Jamovi is based on the software R that is running in the background, and there are many variables and many options here. So you can see there is a survival module. If you click that, this will open. So let me click this, and then you can see there is a time to elapse. So I have moved this variable here, time elapsed, this event or the outcome, which is the relapse. This I have moved here. And then I have taken only this explanatory variable. This is the grouping. So first I am showing you for the Kaplan-Meier, and then in the down, if you come, there is an option of this Kaplan-Meier plot. So I have clicked that, and if you see the output, you can see exactly the similar graph which you have seen in the article. Let me, if you can see that article, there also you can see similar of this sort where the survival curves for the two groups are there. In my case, since it is a dummy data, so in my case, it was the hazard ratio was 1.63, which was the unadjusted hazard ratio. You can add more variables here. I can add like maybe the ANCA type here in the explanatory variable. And if you want to take the duration of the disease also, you can enter here it. So basically, in the Kaplan-Meier, we take only one variable. But if you take the this Cox proportional hazard, then you can see that all other variables are also in place. And this is the hazard regression plot. So similar of this, you can see that it is giving you all type of variables and this box plot along with the confidence interval and the hazard ratio. And this is the table. So you can see that the hazard ratio taking these two groups, unadjusted and adjusted, that is also there. So that's how we do the analysis. So for analysis of such type of data, we need the time of that event, which is the most crucial. And regarding the sample size, I have explained how the author has done the sample size. And he has not mentioned the superiority margin in it. So that's it from my side. Dr. Harsh, you are muted.
Now, am I audible?
Yes.
So basically, I would just like to request you to kindly, in a brief, summarize the normal types of drug trials, like you said, superiority trial, non-inferiority trial, and equivalence trial. And so normally these are the three types of drug trial. So can you just briefly enumerate, I mean, when do we normally use them?
Okay, so basically in most of the clinical trial, you will see that we do superiority type of trial where we fix a superiority margin, which we call it as a clinical significant margin. Now in this, I would like to explain one more thing, that there is something known as the clinical significance and something known as the statistical significance. So in statistical significance, you will get the p-value. Like if you are doing some new drug trial and the difference of lowering of blood pressure is only for 2 millimeter, then it may not be clinically significant for you. So that clinical significant margin, that you fixed it. And then you want your drug to be, at least if that newer drug is more than that clinical significant margin, then you will consider that that is a superiority trial. Most of the trial which we do, that is the superiority trial. The other type is the non-inferiority. So if the drug which is currently in place, if it is very costly or it has got some side effect or some invasive procedure is there, discomfort to patient is there, then in terms of outcome, you plan for a non-inferiority trial, where the newer drug or the newer intervention, it is not inferior to the existing one, but it has got like lesser side effects or cheaper one. So that's the non-inferiority. And in the equivalence trial, what you do, you keep a plus minus, neither inferior, not superior within that margin. But again, it is set in terms of some margin, and that margin is the clinical significant or clinical non-significant. So that's how we define.
Okay, because interestingly, this was the superiority trial, but all the other ANCA vasculitis trials have been the non-inferiority trials. And one more thing, madam, as it was an open label study. Am I audible?
So, superiority trial. Yeah, Harsh, you are audible?
Yeah, ma'am.
Yeah, you are audible, Harsh.
Yes, ma'am. So what I'm saying is, ma'am, all the other trials which were there in ANCA vasculitis were basically non-inferiority trials. So this was a trial which was a superiority trial. So I just wanted to know one thing more from Dr. Pragya, was that it was an open label study and it was a randomized control trial. So we all know that there are some fallacies with the open label studies and all. So how can we minimize the biases in an open label?
So basically, whenever we do an open label study, the very important thing in case of a randomized control trial is the allocation of the treatment. And if there is a concealment of the allocation of the treatment, then one major purpose is served. Now coming to the blinding, because it is a type of study, blinding is another concept which is entirely different from the treatment allocation. So if there is a concealment of allocation of treatment, 50% of the job has been done. Now, depending on the subjective or objective. So here the outcome is objective, like you are measuring something through the blood parameters. So this is more of objective criteria. In terms when there is a subjective criteria, let's say you are measuring pain. So pain is a little bit of subjectivity is there. In that case, you should definitely try to blind if it is possible. Now, coming to the type of blinding, we always say that, single blind, double blind, and triple blind, and open label, and so on. But if you see these things these days, I will just share one screen, and how we should report our blinding, that is very important. So I'll just share this with you. And this is one slide. So now these days, we don't say that this study was a single blind. We should not say. And that consort guideline in 2010, they have clearly mentioned that you should write all the steps of that procedure and then write whether that blinding was possible or not. Again, in this case, you can see this is a standard table for reporting of use of blinding and the allocation concealment. So in this case, you can see that these are the steps of a research, like you do a surgery, like you do other management. So there is a person assigning the participant to the group. There is a participant, there is a care provider, like nurses and all the other staff. There is a lab technician, there is a pharmacist, and then there's a data collector and managers, outcome assessors, and statistician. So what information was withheld? That should be important. Like you can see, allocation, concealment, and group assignment, it was withheld from these groups. And again, if you see the blinding, they have clearly written that concealed allocation schedule, placebo medications, or sham surgery is not told to the group assignment, and then blinding was compromised or not. So these days, if we see the article again, we are discussing like single blind or double blind or triple blind, but they should not be there. Again, minimum blinding, if we see, at least if you are enforcing a blinding in your study, then the participant, practitioners, data collectors, outcome adjusters, and data analysts, they too should be blind. So again, this was regarding the sample size, which I have already told. So this was regarding this. And in this case, if you go for a blinding, then the other group, because there is an injectable group and there is a oral therapy. So what could have been done here, there could have been some other, like sterile injection could have been given to the oral drug one, and some tablet should have been given, may have been given. I'm not saying should have been because it's the researcher choice. That can be done. Because one injection and one oral, you cannot achieve a blinding. But again, like if you give another injection to the oral person, the drug one, and oral drug to the injection, and it should have, like, there are 4 or 5 criteria: the color, the taste, the look, the smell, the packing, everything should be similar for both the groups. Then only we can achieve this. So it's a little difficult thing to achieve, but definitely it can be done.
So it was something which was tried in RAVE trial, ma'am. It was something which was called double dummy trial was the RAVE trial, in which they tried to do this kind of things. So thank you, Dr. Pragya.
My pleasure.
So Harsh, we may proceed to the paper itself.
Yes,
Arun, are there questions from the
there
audience?
There are a couple of questions, ma'am. One was about the total cumulative rituximab dose which one can prescribe, from Professor N.P. Singh, sir. What is the total cumulative dose of rituximab one can prescribe, and what is in general being followed by both of you?
Yeah, should I take up the question,
yes,
or our student would take up? Look, here is a Menritazan trial, Menritazan 1, which has used just the half of the current trial. Menritazan 1 has used around 2,500 milligram of Ritux, while this trial have used quite a large dose of Ritux. In fact, this is one of the difference between these two trials. Why, in spite of a remission trial like Menritazan is there, we have still they have still done another remission trial that they have told that with higher dose they tried to achieve almost zeroing of the B cells. so that there would be no relapse in these 24 months when the drugs will be administered. And they tried to look at that how long this suppression go on to suppress the relapse itself. So they have shown two criteria, the two indicators. One, other than reporting the sepsis, they have shown whether hypogammaglobulinemia, which is always a threat for infection, how much it was there. So less than 3 gram hypogammaglobulinemia or less than 5 gram hypogammaglobulinemia, which was more common in this Ritux group with 5,000 dose compared to azathioprine was there. But luckily the things like higher rate of infections were not seen in this Ritux group. So at least this trial shows us that this much rituximab can be given as a cumulative dose. It was given every 4th monthly. Though we usually give 6 monthly, they have particularly mentioned that they wanted to keep the Ritux level high. They didn't want to precipitate a single relapse in want of rituximab. So that is why they have chosen this 4 months and they have gone for a higher dose. Also, they wanted to see that with higher dose, whether they are touching the higher rate of infection and the limit can be put there. So from these two, it doesn't come that we can use around 5,000. One important thing, Arun, you were telling at the very beginning of the study that whether it is applicable in our country or not. Number one, if you look at the participants are all mostly European, and they have a higher incidence of GPA rather than MPA, and they have taken each relapsing disease, which is an important difference from menritazine. Two important differences. The menritazine doesn't have a lot of good number, underpowered study, because only 23 out of 115 did have relapse, and this trial has taken each relapse. And another is induction was with cyclo in menritazine, and here it was with rituximab. So with these two differences, this trial has separate implication in use of rituximab. And our population, if they are exposed to this much rituximab, and all that they go back to the common household, particularly the patients from the public sector, where a large concentration of humid environment and bacteria are all there, I don't know whether we will precipitate more infection with this much zeroing of B cells.
And
so whether that we need to think twice before giving this large dose of rituximab. This is my bottom line answer.
And also, madam, even in Rituximab, if you see, around 70% patients were already receiving cyclophosphamide. So this was also very interesting. And in fact, the mean dose of cyclophosphamide in this trial was around 25 grams. So patients had already received cyclophosphamide plus 5 grams of Ritux. So this is again a very thing which, as you said, and rightly pointed out, in our setting,
one important thing, there is definitely a legacy of induction, but cyclophosphamide is a drug which is rapidly cleared from the circulation as well.
That is
so
true,
if you take it, exposure to cyclophosphamide will not translate to infection, but definitely the secondary malignancies, cumulative effect of both cyclo and Ritux.
So that's what I'm saying, ma'am. Already, I mean, the cumulative dose even in this trial was pretty high.
Yes, the total immunosuppression burden.
Yes.
Arun, if anybody had asked about the ESRD risk and the need for the duration of treatment, because that is one of the important controversial area. How long
we are having a couple of questions on CD19. So one question was about why do we monitor CD19 instead of CD20, and what level of CD19 to maintain? And is there any role of CD19 levels to decide about remission or relapse? And is it used in your practice?
Yeah, CD19 is not an absolute indicator. You cannot take it as an telltale biomarker of relapse. But usually there is a rise of CD19 followed by a relapse. We expect a relapse when CD19 goes high. Many papers have reported this type of temporal association with high recovery of CD19 and the precipitation of relapse. But definitely some people, even with the zeroing of CD19, also there were some relapses. So definitely the thing is there that even with zero CD19, there might be relapses.
And do you monitor CD19 in your practice?
Actually, the monitoring of CD19 was basically tried in a lot of hematological malignancies where rituximab was used, and they said something around less than 1%. They were not giving the other dose. Routinely, if you ask me, we don't monitor because even the cost of rituximab is high, and doing CD19
monitoring
again,
adds to it.
Yes, so practically we are not doing it, and even what Madam said, the guideline says that you should monitor serum IgG level at 0 months and 6
Yes,
months, and then
exactly.
subsequently. That is also something which we are not doing.
We are doing
So
it.
this is two things which they
That
are
was
saying.
one of our
Yeah.
questions about whether you have a schedule for immunoglobulin measurement following rituximab, or after how many doses of rituximab would you want to do an immunoglobulin test?
So
Before giving rituximab, we go for this IgG test, and if it is less than 300 milligram per liter, we usually withhold rituximab injection, put them on IVIG, and then after 2 weeks or so, when the IgG is in a comfortable level, we go for rituximab.
And
KDIGO guideline says that it should be monitored every 6 months of rituximab dose, 0 months, 6 months, and then as Madam pointed out, that there is some guidelines suggesting that once it is less than 3 grams, you should go for a prophylactic IVIG dose.
And one other follow-up question for that was that what is the maximum duration for which rituximab has been administered by the panelist for relapsing ANCA-associated vasculitis? It's a focus question.
We
how
were
long
not
maximum duration you have
previously
given?
we were not giving. We were giving azathioprine. I think from 2017 the evidences are growing in favor of rituximab maintenance, and until and unless rituximab is available in the public sector, it is difficult for your panelists to use it for a large number of patients. But nowadays we are using rituximab for remission, inducing remission in. But one more thing, Arun, we are getting more MPA patients, and VDI, if I measure the vascular damage index, the total damage accrual, that is becoming high in the patients. So sometimes after we are doing a second biopsy or assessing VDI score, and we are not going to immunosuppress if the chronicity load is too high.
The next question was about, yes, sir. Yes, sir,
we have
please.
been using Ritux and other membranous as well. So probably what we have tried is that we have not exceeded 2 grams or 3 grams, something like that. So practically, we don't have a data on till we are using it more commonly. We still do not have that data.
Yeah. Same for me.
And one other question was on whether there is any experience with daratumumab in conditions where even after CD19 depletion, there is a relapse.
Which drug?
Use of daratumumab.
Even after CD19 depletion, if there is a relapse,
which drug?
Daratumumab.
No, I don't have experience.
So I think Dr. Indradeep had this question. Probably
In multiple myeloma setting, we have used daratumumab.
Anti-plasma cell CD138. I think you have not used it in
We haven't used it.
vasculitis.
We haven't used it, but probably the role is coming gradually, but we haven't used it.
Perfect.
But there is an important question that remains to be answered. What should be the ideal duration of maintenance? Initially, it was told that after 2 years, we should discontinue steroids, we should discontinue the anti-proliferation. So people try to continue for up to 48 months. But even after 48 months, if the drug is stopped, whenever the immunosuppressives are stopped, there is a chance of relapse. Another important question that should come in, Arun, is about steroids, because we are repeatedly using many drugs. We are able to save most of the patients during the first disease state. So they will come repeatedly with relapse if PR3 people are high, or even in MPO people we can find relapses. So, so what will be the dose of steroid at relapse? Somebody has asked that, or whether we will go for a very short low dose steroid, because infection is a very important issue in our country. So this trial has shown that 0.5 mg and 1 mg, what they have shown 1A and 1B group, they did not have much difference in outcome. And if you remember the Pexivas, the lower dose steroid group, that had shown that there was 40% lower dose of steroid exposure, and that practically didn't result in much worse outcome, rather saved from some decrease some severe infections. So I feel that we should try to go with a lower dose of steroid. In fact, whenever we give cyclophosphamide, we come down in steroid dose to 0.5 milligram immediately, 0.5 milligram per kg immediately. And we try to come down to 5 milligram dose of steroid by 20 to 24 weeks. And the similar protocol has been used in the rituximab steroid tapering, and also in Ritazarem steroid tapering.
So Pexivas was the first, first genuine effort to, somehow test the dose of steroids. And one more thing which I would like to know from, probably I don't know whether that question has been asked or not. I would be interested in knowing that in this Ritazarem relapsing patient, how many of them had a very severe renal disease? Probably that is something missing in this paper. They were saying that they had major disease activity, but like in RAVE, the severe renal disease was excluded. So I would be interested in knowing that what proportion of patients had severe renal disease in this relapsing patient. Number one. Number two, I would also be interested. I don't know whether the paper, because I read the paper and it was not mentioned anywhere, that in the patient who had the history of cyclophosphamide intake, in those proportion of patients, how many had relapse? So that was
Harsh, the question was haunting me too, that whether we can apply rituximab induction also in severe disease.
Right.
I went to look into the other trials also. There is a Pexivas subgroup analysis where Ritux has been used to treat severe disease,
And
but the number is so
Ritux
less that you can't. Ritux to treat severe disease, they have shown that it is non-inferior to cyclo, but the number is so small that you should not come to a conclusion.
Right.
And till now in the clinical setting, whenever we see a severe organ-threatening disease, we do not go for Ritux, we rather go for cyclophosphamide. Even if you listen to Dr. David Jain in several occasions, he himself does this. So, so what about this trial? I don't feel that these 170 patients who had been taken into, they had severe renal disease.
Yes.
Because you know that a severe renal disease is usually not that way relapsing. They have taken almost every patient at relapse. So they haven't mentioned that whether it was a severe organ threatening disease anywhere, but there was no description in the patient's part. As they followed the concert reporting, they reported about patients in detail. There was no report that some patients required dialysis at the beginning. So DH or dialysis, both were not mentioned in this group. So probably these are relatively non-severe patients, and most are PR3.
And as a nephrologist, we usually see patients who are comes to us in a pretty late stage of renal disease.
Yeah.
So even if I will just ask for induction, what would be the drug which you would be preferring for a severe disease, non-severe disease, for a dialysis requiring disease, for a AAV patient?
I will say no to cyclophosphamide as induction agent if it is a non-organ threatening disease. Suppose it's a small nodule, suppose it's just focal crescentic GN and focal crescents, or it's sorry, if it is renal, it is always organ threatening. If it is scleritis, if it is ENT, ER related or eye related issue, I will not consider. Rather, I will go for the cyclophosphamide versus oral cyclo reference of NORAM trial and say that methotrexate might be enough to treat that. And there are SIG versus MMF trials also, which in severe disease, the MMF has never performed well. So I don't know whether any trial is there in non-organ threatening disease with MMF. That can be an area of research. I don't know any trial with MMF in non-organ threatening disease. Number 2 is if the disease is too severe, that the patient comes with dialysis requirement and DH with hypoxemia, I will consider MP pulse and cyclophosphamide both along with plasmapheresis. DH without hypoxemia, I may wait to use plasmapheresis, but I will go with cyclophosphamide and MP pulse. And for this type of patients, I may go for rituximab. Those patients who are PR3 positive or early MPA, not a chronic, not an MPA disease with lot of chronicity burden, I will choose rituximab because I will. They in 2 different studies. I think 2, not 3. RAVE, rituximab, and now rituximab induction phase as well. They have shown that it is quite comparable to SIG and rituximab. We use for long term. What secondary malignancy we are going using cyclo for long time, we get signals that where cyclo is wrong. We are yet to be so much confident about retux.
Dr. Harsh?
Yeah, same. I think the same view as Madam has just now said. I think it is pretty well in the recent 2021 KDIGO guidelines as well. As a nephrologist, we have definite recommendations for that. To add to what Madam said, it is very true that we need to really relook at the rituximab, how it has been presented to us. In fact, there is a Roche survey which they are now looking at all the side effect profiles in almost all the diseases in which Ritux has been used. And it is a part of their phase 4 marketing survey. It is about to be published data. And we really need to look at Ritux, and that too in the COVID era, which we have just now, the COVID era, which is just now gone. Even in that era, there was a serious question about using rituximab in these subgroup of patients.
Yeah.
In fact, as Professor Jane from Addenbrooke say, that if we are not vigilant, there would be a time where after in ANCA vasculitis, we would be treating more chronic severe combined immunodeficiency than vasculitis patients. So these are his words. So we need to really, I'm not saying that it is a bad drug. What I'm saying is that the kind of euphoria which we have currently about this drug, we really need to look at it in a more, critical way. So that's my point. So I personally believe that still for severe renal disease, the traditional of KDIGO 2021 guidelines says, go with cyclophosphamide, pulse and all that. Probably I feel that Ritux for relapsing patients, you can try, or there is evidence for that. So probably you can say, as this before Ritazeram, Professor Glascock said, that probably it is rest in peace as a. So I don't know.
Yeah, they're dumping as a. And Harsh, the COVID era, as you have mentioned, in COVID era, I have avoided rituximab because it is a drug which acts for a long time. And I do not know whether the patient will be, with COVID and super infections and all. So in COVID era, someone was asking for data. Now, I just withheld using rituximab in the COVID era. I rather use cyclo in patients coming with GN, bad GNs, because cyclo can be cleared from the circulation.
Have used cyclo?
Effect is long lasting.
Right.
Before we conclude, we'll just take one last question on whether we can go for a combination of steroids, MP pulse, cyclophosphamide and rituximab in severe disease as induction?
Rituximab has exemplified that and showed that it is no superior outcome than cyclo alone. Sandwiching cyclo with Ritux is no superior to cyclo alone. So, so for very severe
Combination
disease,
of all three: steroid pulse, cyclophosphamide, and rituximab.
yeah, for severe disease, cyclo and MP pulse is must that I do. But adding Ritux on top of it, I don't know. I maybe if I don't get any remission by 3 months, I can sandwich a Ritux with cyclo. That I have done in severe lupus sometimes. I supported with IVIG and then I gave sandwiched Ritux cyclo in dialysis, severe lupus, sort of APLA and complicated.
I think.
But with ANCA, I have never done it.
It was only tried in Rituximab, and probably the data, I mean, we all know that it was not a very, data which was not very convincing.
I would like to thank Dr. Sudipta, the presenter, our panelists, Dr. Harshvardhan and Dr. Arpita ma'am for such a wonderful JC presentation. We did have some more questions on statistical analysis, which especially about hazard ratios, which probably we'll deal with in the next journal club, where we'll have a short presentation by one of the statisticians. And we will try to have this on the third Wednesday every month, as mentioned earlier. We request all of you to participate actively. And once again, thank all of you on behalf of ISM, Dr. Darshan and Dr. Shamban. Thank you.
Thank you very much. And
Thank
I must
you.
congratulate for this wonderful initiative by Indian Society of Nephrology. I think this is going to be a long way and something which is going to have a very positive outcome.
Thank you. Thank you, sir. Thank you, ma'am.
Actually, there should be a spark of thinking. So this type of lies it on your own experience, reading and reread and recalculate things and get inspiration for a trial launched by you alone for the students.
Yeah, I think this would probably stimulate all of us to have well-conducted trials, especially which focused on our country.
And there is a high time that we should have our own GN guidelines, madam. What do you think, ma'am? I think we should have.
Data will be limited, Harsh. We do a lot, we think a lot, we write very, very less.
Yes, that is true, ma'am.
True.
Thank
Probably,
you.
I think this should change. This is our motto of changing it with the present JC.
Yeah,
Thank you. Thank you.
Sorry.
Thank you, sir.
Thank you.
Thank you all. Thank you all.